we got significant improvement on measures of depressive symptomatology and functioning from pre to post-treatment across all treatment conditions, including the placebo plus clinical management condition. There was no significant difference between the two psychotherapies. The imipramine condition, and I'm not going to always bother to say the CM, so you'll know that it's always that combination. The imipramine condition was significantly superior to the placebo, so it was an adequate reference condition in the study. And this was mostly because the effects of imipramine were more rapid. There were also more rapid imipramine effects, as you can see, than the effects for the psychotherapies until 12 weeks, and then the psychotherapies caught up. So by 16 weeks, there were no significant differences between the psychotherapies and imipramine. We also did some analyses in our initial report of findings. We had some analyses on recovery rates, and for the entire sample now, IPT as well as imipramine had significantly higher rates of recovery than the placebo condition. In regard to the specific effects of the treatments in the areas that were targeted by each of them, we looked at measures of social adjustment, particularly relevant for IPT, measures of dysfunctional attitudes, particularly relevant for CBT, and measures of endogenous symptomatology, particularly relevant for the pharmacotherapies. Okay, from the very beginning, we were interested in the role of initial severity of the depression. And we did significant severity by treatment and by time trends when we were doing the random regression modeling analyses, and we found significant interactions using a measure of severity based on the Hamilton Rating Scale for depression and severity based on the Global Assessment Scale, which measures both severity of depression and impairment of functioning. So our next slide shows some of the severity results. We divided the patients into high and low severity groups. And on the left hand, you will see the division using the Hamilton Rating Scale for depression as the severity measure. There were no significant differences for the very severely depressed. And I want to emphasize that, by the way. That includes placebo condition. And I want to emphasize that because about 60% of our patients actually fell into that low severe group. There were significant differences, however, for the more severely depressed, with the Hamilton as the severity criterion on your left. Imipramine was significantly superior to both CBT and placebo, and there was a trend for IPT to be superior to CBT and placebo. On the right-hand side, with the Global Assessment Scale for the criterion, so this is now including not only depressive symptomatology, but also impairment of functioning, imipramine was significantly superior to the placebo condition. You can see the two psychotherapies there in between, but the significant difference was between imipramine and all of the others. Also secondarily, I don't have a graph for this, we used the Beck Depression Inventory, a self-report measure, as both a severity criterion and an outcome measure. And there, both imipramine and IPT were significantly superior to placebo and CBT. I need to point out that the termination scores for the patients in CBT, although the CBT condition fared a little worse than IPT in the study, that the CBT scores at termination were very similar to those in most other studies of CBT. And we also have to remember the nature of the imipramine plus clinical management condition, that it's essentially the drug plus a minimal supportive therapy, a very stringent reference condition, and the placebo is also a very stringent control condition. The superiority for imipramine didn't hold up for the follow-up. In order to keep the randomization of treatments, there are a lot of difficulties in analyzing findings in follow-up studies. But in our major analyses, and Tracy Shea was the lead author on our paper reporting this, what we looked at in order to keep the randomization of our treatment conditions, the original randomization, we looked at all patients who entered treatment, who recovered, and who didn't relapse over the 18-month follow-up period. There were no significant differences, but CBT and IPT did somewhat better than the pharmacotherapy conditions. What was very striking about these findings, however, were the low percentage of patients who met the criteria, and they were pretty stringent criteria, who met the criteria of recovery and relapse. The percentage, and no relapse, sorry. The percentage reaching that criterion was 30% for CBT, 26% for IPT, 19 and 20% for the pharmacotherapy conditions. Recognizing the stringency of the criteria, as I said, for both recovery and relapse, and the fact that many patients, including those who didn't, quote, recover, were relatively free of depressive symptoms during the follow-up period, for many weeks during the follow-up period. These results still should give us some pause, suggesting that some of the patients may have needed longer treatment and some might have benefited from combinations of psychotherapeutic and drug intervention. So that is where I'd like to close the first part of the presentation, and I understand we now can go to some questions that people may have to like to ask, if we can figure out how we're going to get that.
Yes, we don't have any questions yet, but let's give people some time to ask them.
Okay, fine.
So remember, if you want to ask a question, you can type it either in the question window or you can raise your hands. Yes, I have a raised hand. I hope I'm pronouncing this correctly. This is Su Young Yoon. I'm opening your microphone right now. Go ahead. You can speak. Okay. Oh. This was a mistake. Okay, so let's just continue then. There are no questions at this point, it seems.
There are no questions. Okay. I think the second part's going to generate questions and discussion. I certainly hope so. I realize that people may have had various types of exposure to the study, so some of you may know a good bit about it before you came to the webinar. Okay, so now we're going to talk about the heart. Now it's going to be the heart of this talk, and that's on the disentangling dilemma. So what do I mean by that? Well, I'll go into that in a minute. Let me just run quickly through what's on this slide so you get an idea of where we're going to go during this second part of the presentation.
Can I interrupt? Because we do have a question coming up right now. So it took a
Okay, that's fine. That's fine. We haven't gotten into the meat of it, so that's fine.
Okay, so I have a question by Jim Payne. Jim, if you have a microphone, you can raise your hand and I'll open your mic. Just wait for 1 second. Yes. Go ahead.
Yes, Dr. Elkin, I would like to ask if there was any information about the time to relapse in each one of the conditions.
The time to, I'm trying to remember if in the paper that Tracy first authored, whether we have differential times to relapse. I think it may they may very well be. I do not recall for sure, but I would suggest you, it's not one, I have a very short list of recommended readings at the end, but you can find the reference to Shea et al. In the chapter in Bergen and Garfield that I have in the recommended readings. You can find the reference to the major article, and she has a lot of things in there. She does have, for instance, for those who recovered, what were the rates of relapse. That becomes a sort of selected sample at that point because not the same types of people necessarily recovered in each of the treatments. So I know she had that. She may have the information you're looking for. I'm not sure.
Okay, thank you very much.
But I suggest you look at that article at starters, and you can also get in touch with Dr. Shea at Brown if you need to for further information on that.
Thank you again.
Sure. Thank you for your question. Okay, let me just go and run down the things I'm going to cover in this second section. I'm going to talk about the disentangling dilemma, what I mean by that, and how it emerged as a dilemma, for me at least, and as for some others, how it emerged in the context of our carrying out the collaborative study. Then I'll talk about implications for outcome research, implications for the design and implementation of studies, for the write-up of studies, and for the interpretation of findings. I'll also talk some about what I see as a need for pan-theoretical measures of competence across different treatments to the extent that that might be possible. And I'll finally talk about some dissemination issues and how the dilemma is relevant there too. So the dilemma. When you look at the outcome results for specific psychotherapies, especially I think this is important in comparative studies where you're looking at outcome of 2 or more treatment conditions. How much is due, how much of your outcome is due to the specific psychotherapeutic approach, and how much to the sample of therapists who are carrying it out? We were aware of this issue early on. In fact, in our 1985 article, which was a background paper describing the collaborative study, we said the following. The treatment conditions are, in actuality, packages of particular therapeutic approaches, and the therapists who both choose to and are chosen to administer them. And we attempted to address this issue in the design and implementation of the study, trying to keep comparable requirements for various things across the treatment conditions. Comparable requirements for selecting therapists, for training the therapists, and for the therapists having to meet competence criteria. We also, of course, gathered a lot of information on various therapist variables, and we investigated therapist effects. And I'd like to clarify something here to make sure we don't have confusion about it, that what I'm talking about today is different from the issue of therapist effects. Therapist effects are concerned with variability due to individual therapists within treatment. Here, we're focusing on possible differences in the samples of therapists, differences across treatments, particularly in regard to their competence in carrying out their respective treatment approaches. So let me tell you something about, this is what my students used to call Irene's research stories. Let me tell you something about how the dilemma raised its head in the course of our carrying out the collaborative study. The first clue I got to something going on in regards to the dilemma was in the trainers' descriptions of their therapists. The IPT trainers were generally very enthusiastic about the level of competence of most of their therapists. However, the CBT therapists talked about the fairly wide range of performance of the therapists, although the therapists all, of course, had to meet competence criteria, and these were based on ratings not only by the trainers, but also by other experts in the field. Okay, my second clue about something going on here were something we called red line calls. During the training phase, which was also the pilot phase of the study for looking at instruments and so on, so during that training/pilot phase of the study, the therapist received weekly supervision. They sent videotapes back and forth. They had weekly phone consultation, supervision really, weekly supervision by phone with the trainers. For the outcome study, because we wanted to make things a little bit closer to the real world, we went to monthly consultation in the outcome study itself, plus what we called red line calls. Each training site was asked to set a standard level of competence below which the therapist's performance would not be considered adequate. If a trainer saw a tape that met the red line criterion, the trainer would call the therapist, and there would be another consultation call, essentially, targeted at those problems that had appeared in the therapist's treatment approach. And so the thing that caught my eye was the different percentages of tapes that were followed by red line calls. It was 33% for CBT and only 3% for IPT. Now there's a possibility, of course, that the CBT trainers were using a more stringent criterion. Theirs was a more quantitative criterion. The IPT trainers had a more qualitative criterion. But nonetheless, that seemed like a pretty striking difference, 33% versus 3%. Third clue. We looked at the trend of the competence ratings that were given for each therapist across the training cases, the 3 or 4, some cases it was a little more, the 3 or 4 training cases, and then the first outcome. At that point, we were looking at the first outcome study case as well. For IPT, the therapists got to a high level of competence by the second training phase patient and maintained that level throughout training and through the first outcome study patient. In CBT, there was gradual improvement during the training phase, and then that dropped off some on average for the first outcome study patient. Again, it's possible that there were differences due to different kinds of competence criteria. But we had asked each training site to use and or develop a criterion appropriate for that treatment. And let me digress a little bit from my topic. It's not a digression because it has to do with psychotherapy research in general. And that's that we felt we were constantly, I've sometimes called it the grand compromise in psychotherapy research, kind of walking the line between being as rigorous as possible in terms of our research standards and at the same time trying to respect the integrity of each clinical approach that you're studying. So this was a case, for instance, in which we asked the trainers to develop competence criteria that would be true to the goals of their own treatment. Going back, I wanted to get more directly at the possible difference in competence in two treatments. And so we introduced a common, although admittedly a very crude measure, we asked the trainers and the outside experts in each of the approaches to rate each therapist on a scale from 1 to 7 on how close the therapist came to the rater's concept of the ideal therapist for his or her treatment condition. The IPT therapists rated their, the IPT trainers rated their therapists as significantly closer to the ideal than the CBT trainers rated their therapists. The mean scores were 5.3 and 3.7 on the 7-point scale. In thinking, so clearly we were coming to the impression that the cognitive therapist might not have been carrying out the treatment in as competent a fashion for that approach as the IPT therapists were in IPT, recognizing again that the final scores were very similar to those in other studies. In thinking about the possible reasons for this, I kept coming back to something that was said by Jean Phillips, a member of our advisory group and a very wise clinician and researcher. And she had pointed out that there might be some problems in comparing what she called an old therapy, in this case IPT, very similar to many psychodynamically oriented therapies, although focused on acute treatments of, treatment of acute depressed episodes, and CBT, which was at that time a quite new therapy. So looking at the previous experience of the therapists, we found that IPT therapists had experience, they'd all had experience in using psychodynamically oriented therapy, both long and short-term therapies with depressed patients, and none had used either cognitive or behavioral approaches with depressed patients. The CBT therapists had used at least some cognitive or behavioral approach. That was part of the criteria for getting into the study. But 7 of the 8 had also had experience using psychodynamically oriented therapies for depressed patients. So they might have had to not only learn some new things, but also possibly to unlearn some things. So although we began to recognize the possibility of problems due to the issue, to the dilemma issue, our first publications, like those of most outcome researchers, were on the differential outcome of different treatment conditions. But I continued to ponder this question. And when Alan Kasdan, who was then editor of Clinical Psychology, Science and Practice, asked me to write about something that I felt I had learned in the process of coordinating the collaborative study, I chose this topic. I don't think I really, so this, the paper that was then published in Clinical Psychology, Science and Practice, and my talk today are based on that thinking. I don't think I have a real answer to the dilemma. I don't know if there is one, but I do think that we need to think about the implications of the dilemma as we do and interpret the results of psychotherapy outcome studies. So let's talk about the implications in different areas. I see it's not bad that we still have the slide up that talks about the different kinds of implications. First of all, in the design and implementation of the studies. It's important to do as much as one can to ensure consistency, where you can get consistency across treatments. In the TDCRP, we did try to focus on trying to have comparability in a number of ways. Comparable criteria in the selection of therapists, including not only minimal levels of experience, but also of experience with this kind of patient population. We wanted to have comparability in training, as you've heard, and supervision of therapists, and assessment on skills relevant for the particular treatment. I think we did pretty well on this, but it clearly doesn't give you a guarantee about disentangling the therapy from the therapist. Secondly, implications for the write-up of studies. And I think this is really important. I think we need to provide information not only about therapist characteristics, and a lot of this is generally done in terms of demographics, experience level, and so on, but also about training and supervision and consultation. There's real implications for generalizability here. For example, would the results with intensively supervised therapists in the study, and I must say, we tried to come down to the consultation in the outcome study. A number of studies have been done which continue intensive supervision throughout the outcome study. So would those results be similar to what would be carried out in the community by therapists who had not received that intensity of supervision? I'd like to mention a really great example of somebody who was very aware of that issue, and that's Marsha Linehan. In her description of dialectical behavior therapy with borderline patients, she said that she considers the support provided from other therapists and consultants in supervisory consultation team meetings extremely important in working with this population, and that she considers it as integral, and I'm quoting from Marsha here, as integral rather than ancillary to DBT. It's a part of the treatment condition. Let's go on then to the implications for interpretation of findings. We have to be aware not only in looking, I'm sorry, I'm going to backtrack a minute. We have to be aware that we're looking not only at the psychotherapy approach, but also, as I keep saying, at the package. And I think we should be reporting any indications of differences that could lead to possible differences in competence with which therapists are carrying out the treatments. I do this in the Dilemma article. I think I should have done it a lot earlier. And so what I'm trying to do, what I tried to do in that article, and what I'm trying to do today is to pass on this learning to other people. That's one of the reasons that when Kim asked me to do this presentation, I said, well, I'm not really taking on anything else now, but I will take this on if I can talk about the dilemma. I've been doing a lot of thinking, and I particularly, as I was writing this paper, was doing a lot of thinking about the possible need for a pan-theoretical measure of competence. And I tried to make the very initial step in this by adding the ideal therapist rating in the TDCRP. I recognize that it may not be possible to have such a measure due to the intrinsic differences in the different approaches. But I think it's useful to begin to think about it. One component of a therapist's competence is, of course, his or her ability to develop a productive relationship. There we do have some answers in the use of pan-theoretical measures of therapeutic alliance or relationship. And I might mention that in Jan Krupnick and colleagues' article on the therapeutic alliance in the TDCRP, we found that the alliance levels for the cognitive therapists and interpersonal therapists were very, very similar. So we do have very, very little difference between them. It becomes more difficult, of course, when we consider other aspects of the treatment. But we might get some ideas from the psychotherapy research literature, from such things as the therapist characteristics that have been related to poor and good outcome in different studies and so on. But I'm going to suggest, I make several suggestions in my article. One of the things I'm hoping for today is to hear more suggestions from all of you. I think that you're probably more up to date on the recent literature, in fact, than I am. So I'll be looking forward to your suggestions. But let me mention a couple that I included in the article. The first one was drawing on Marv Goldfried's conceptualization of pan-theoretical principles of therapeutic change, which focuses on the construct of therapeutic strategies, rather sort of in the middle, so therapeutic strategies rather than theoretical formulations or specific techniques. So just an idea, one might try to develop a competence measure based on the adequacy of therapist intervention for accomplishing goals shared by different treatment approaches at specific phases of therapy. For example, goals of adequate assessment within the context of the psychotherapeutic approach, adequate case formulation, adequate strategic approaches and interventions consistent with the formulation, and adequate handling of termination issues. And as I was writing these notes, another one came to mind, which is adequate handling of alliance ruptures, which have received so much attention in recent years. So as I said, we could also draw on findings in the literature, in the vast literature on therapist characteristics related to outcome. But I also wanted to think about therapist behaviors that contribute to positive or negative change that have been looked at in intensive studies of therapy process. And so I'll just throw out a couple of examples. Both of these happen to be related to what might be considered negative indicators in terms of competence. And the first one I thought about was in the studies by Bill Henry and Hans Strupp and their group, the finding of negative effects of what were called, and I think this was within the SASB system, of multiple or complex therapist communications, what we could think of essentially as mixed messages. Another that came to mind, again on the negative end of the competence issue, were findings by Laura Rice and her colleagues about the negative impact of therapists responding to patients' secondary rather than primary emotional reactions. So these were developed within particular theoretical frameworks. I think they're relevant to other treatments as well. And these would, of course, constitute only a small part of a measure of competence. There are many other possibilities, as I said, and as I will finish my remarks in a few minutes, I'll be very interested in your thoughts on this. Before I close, though, I do want to talk about the area of dissemination. I think that the whole dilemma issue is very important here, especially in the dissemination of the research findings where specific treatment approaches are labeled as empirically supported or empirically validated. Although the APA task force reports, and I'm acquainted with the first two American Psychological Association task force reports, there may be more since then, they do focus on training of therapists in the supported or quote validated treatments. Nothing is included in the listing of treatments about the necessary therapist expertise, training, supervision, or competence required for efficacious practice of a specific treatment. Yet these treatments, too, are actually treatment packages, as I've talked about them. I think I have enough time just to read a little bit from the last paragraph in my paper on the dilemma. So I will close with that. We may never be able to truly disentangle the effects due to the therapist from those due to the therapy, because they may often be inherently intertwined and also very interactive with particular patient attributes. Although there may thus not be any true resolution of the dilemma posed in this article, in this case in this talk, it is important that we acknowledge that the dilemma exists and address it. In evaluating the efficacy of any treatment, we must always bear in mind that the therapist is an important player in the therapeutic enterprise, as is the patient, and that treatments are never disembodied entities equally effective in the hands of different therapists. And that's what we could do is put up the last slide as we start to ask for questions. And the last slide is just a chapter and 2 articles which provide in much more detail the information that I was talking about today. So I guess we go back to you, Kim, and to questions.
Yes, I'm here again. Yeah, let's just wait for people to raise their hands and ask questions.
And give suggestions.
So while we're waiting, I'm going to grab my opportunity to ask you a question myself.
Sure.
One of the things that your talk reminded me of, especially the last part, is that what we see now in psychopathology research is that a lot of people are investigating a trans-diagnostic approach, which is, I think, in a way similar to what you are suggesting.
I missed a little bit of what you said, that they're now investigating what?
Trans-diagnostic approach.
Trans-diagnostic. Trans-diagnostic, yes. Yeah, right.
And so they're looking into symptoms rather than disorders. And I thought it was a nice parallel to what we could do in psychotherapy research with therapies. So rather than look at the therapy as a whole, we should be looking at sort of the symptoms parallel of therapies.
Yeah. Well, it's interesting because along with my notes this morning, I had brought the advertisement for this book called Transformation in Psychotherapy. It's a new APA published book edited by Louis Castengay and Clara Hill, a recent constant duo in having these wonderful conferences and these books. And the title is Transformation in Psychotherapy, and the subtitle is Corrective Experiences Across Cognitive, Behavioral, Humanistic, and Psychodynamic Approaches. And I was thinking, you know, this is the kind of direction that some people are starting to go in, and of course SEPI, in its the Society for the Exploration of Psychotherapy Integration, has as one of its purposes sort of trying to look at things that cut across different treatment approaches. But I think, is that the kind of thing you're thinking of, Kim?
Yes. I think that is what some people are investigating, and I think we could maybe even break it down some more. Corrective experiences may also be a large topic already, so, you know, try to break it down into really small parts of the therapy that might be helpful.
Right. Well, as I was talking before about looking at assessments, the adequacy of assessments in different treatments, the different phases of treatment. But here, for example, in looking at this on corrective experiences across the different treatments, thinking about the therapist's competence in facilitating those corrective experiences.
Mm-hmm. So we have a question from Christian Gold. I'm going to open your microphone right now. Go ahead.
Hello. Hi, my name is Christian Gold. I'm greeting you from Norway. And I very much enjoyed your talk mainly because we are also trying to do some multi-center studies. We are trying to set up international multi-center RCTs on music therapy for various disorders. So I very much enjoyed your talk about the different challenges that this kind of research brings up.
Right, thanks.
It's very helpful for us. Now my question is, the competence ratings, the theoretical or whatever kind of competence ratings, now I need to think about how to ask this correctly. Why do we need them? I was going to say, but that's not really my question. What would they help? I think that's my question. Because what you found out in the main study, so to speak, is that the therapies maybe didn't help as much as you were hoping they would. And then the part of the solution might be to look into whether they were delivered competently or not, and maybe CBT wasn't delivered as competently as IPT, maybe not as competently as it could have been delivered. But on the other hand, all of the therapists tried their best and were trained rigorously, and probably more rigorously than would be the case in ordinary clinical practice. So the question that I'm asking myself is, would it help to have a therapy that in theory is great, but and you find out that it is great, but nobody can really conduct it successfully? How would the competence rating help us there? Before I finish the question, I would also like to say that I would like to add that we are thinking very much in the framework of pragmatic trials of effectiveness, and there the approach is maybe much more what is there in the real world rather than what is the ideal situation. So what would be your answer to that? I'm curious.
Yeah. Boy. Well, of course, if it can't be carried out competently, then we might question whether we want to pursue further work with this particular treatment or figure out what we need to do to improve the training of the therapist. I think in our case, I mean, partly because the therapy was, I think in our case, and the reason I'm sorry that I did not address this earlier, is because it speaks to the question of, in looking at cases, some instances in the study in which IPT seems to perform better than a CBT, we have to qualify that by saying the CBT therapist might not be carrying it out at the level that would have been preferred. So that's just in terms of what we put out there for the field. But it also, if you find that your therapists aren't coming up to the competence levels that you would like for them to be coming up to, it makes you think a lot about the treatment and about the training, how much training is necessary. I agree with you, if an awful lot of training is necessary, maybe it's not going to be relevant in the real world, but we need to know that. We need to know how much training is necessary and what does that training involve in order to be able to speak about the results. In thinking about this, you know, I'll tell one of my other research stories. Tim Beck himself was going to be conducting the training program in CBT. And the original idea had been that the training probably wouldn't take much more than 6 months or 6 months to a year or something like that. And what he said was that that wasn't sufficient, and that he was concerned that a therapist might not actually meet his criteria, even if they met other people's criteria, that they might not meet his criteria. And he didn't want to, he did the initial training institute, but then the grant application ended up being with Brian Shaw, who had trained with Beck and had been one of the people in the original Rush et al. Study at Penn. So that, you know, maybe you do need more supervision, and maybe therapists out in the real world need more supervision than they get many times. Now, we do have the additional issue back then that this was a relatively new therapeutic approach, but relatively new therapeutic approaches are always coming along. And so the question is, where therapists have been trained in another approach, I think it's another implication of this work we've done, where therapists have been trained in another approach, you need to be sure that they're really reaching the level of competence now in this approach. I don't know if that answers your question. I'm really aware of the big question of being able to generalize from any rigorously controlled study out into the real world, of course. But for example, going back to what Marsha Linehan said about DBT and about their therapist and consultant team meetings, I attended one of those, so I really realized why she thought they were so important. And she says that's got to be part of what happens in DBT training and carrying out the treatment, and I don't think that that's always done. So I'm just going to stop there. I hope I've at least addressed part of it.
Okay, so Irene, I have a couple of questions that I got through the question box. I'm going to mute you for a second because I have an echo and it seems to be bothering people. I'm going to start with the first question. I think you addressed it partly already. It's from Brian Pace. He says, I am unable to raise my hand due to waiting for class to start, but can you speak briefly about supervision in trials influencing outcomes, e.g. the amount of supervision influencing effects? We are doing research here at the University of Wisconsin regarding supervision in RCTs, and I'm very interested in this topic. Thanks.
The importance, if I understand this correctly, the importance of supervision in the outcome. Is that the question basically?
Yes, that's what he's asking. The amount of supervision that is influencing the effects. He says yes, basically. He replies to me.
Yeah, and I think that's going to differ for different therapies. And it's going to differ, as I suggested, depending upon how much experience a therapist has had with other therapeutic approaches and with this specific therapeutic approach. So that I think the amount of supervision can be very important, and that's one of the major things I'm trying to address here. And you know, perhaps had we had more supervision rather than just the consultation during the outcome phase of the study, that might have resulted in higher competence levels for the cognitive therapist. But again, we were trying to get something that would actually be closer to the real world. So it's again one of those, when I gave my address when I was president of SPR, my address was called The Great Compromise, something else, psychotherapy and research. It was essentially the compromise always between the real world and the real clinical issues that you're dealing with and the rigor of. But certainly I would feel that after you do a certain amount of supervision, to get competence criteria all along the way is extremely important. Something else occurred to me as I was talking right now, which is aside from supervision, I think something that we don't realize sometimes is so important is how much experience the therapists have had with a particular patient population. Now, not just the therapy, but with a particular patient population. And I was looking back at some of the reports of the collaborative work by Paul Kritz-Christoph and his colleagues with patients with cocaine dependence. And they had several different treatment conditions, but one of them included treatment by individual drug counselors, and that was combined with group drug counseling. And they found, and that group did very well, but those counselors had actually had a considerably greater amount of experience with the patient population that they were working with. So it's another part of that package.
Thank you, Irene. I have another question. Yes, I have, Brian, by the way, says great, thanks. So he's grateful for your answer. I have another question from Catherine Reich, who is in Memphis. She says, the therapists who conducted one treatment were a different group than the therapists that conducted the other treatment, correct? Assuming so, my question may be naive and implausible given my lack of experience conducting this sort of research, but wouldn't it help if therapists were trained and implemented both therapies in the trial instead of solely one treatment?
Okay, great question. I'm glad it came up. I address it in the paper. And I'm sorry I didn't address it already today, so I'm really glad you raised the question. Essentially, crossing therapies with therapists. A much neater research design, but not necessarily feasible. So let me give you an example. David Shapiro and his colleagues work in England, where they did use 2 psychotherapies, one pretty similar, I'm trying to think of what it was called, directive something, pretty similar to CBT, and one pretty similar to IBT actually, for depression. They had the same therapist. There were only 3 therapists involved in the study, I believe. Maybe there were a couple more. There were 3 main therapists on a couple more of seeing fewer patients. So they had those therapists carrying out both treatment conditions. And their initial reports of their findings were that the more directive, the cognitively oriented therapy did better. They then later published a paper in which they looked back at the 2 therapists who had seen the greatest number, 2 or 3 therapists who had seen the greatest number of patients in the study. And the results that they had previously reported were basically due to one of the therapists. A therapist who happened to do a lot better in a more directive approach than in the other approach. And therein lies the problem with crossing therapists with treatments, in that it would seem to be very difficult to get therapists to have the same amount of relevant experience, the same amount of enthusiasm, the same amount of competence, ability to develop competence, the same amount of commitment to 2 different treatment approaches. There's been some of that done. There has been some other research done like that. There was research done, for instance, I think Neil Jacobson and some of his people in more behavioral and cognitive behavioral approaches, in which they did dismantling studies. And there the therapists were doing treatments that were much more similar to each other. And so it might be more possible. I don't know exactly what happened in some of the studies. I'm trying to think. I think that in some of the studies at York, where they looked at client-centered therapy and then looked at client-centered plus process experiential elements, I think in some of those they used some of the same therapists. But basically, it's really hard, I think, to try to get, it's a good question because it's an obvious possibility, but I don't know if it's impossible, but I think it's very hard to end up getting the same level of expertise and commitment to 2 different treatments. Thanks for the question.
Thank you, Irene. I have another question from an anonymous person in Trier, because they're watching with a group, so I don't know who's asking. But the question is, after finishing this large study and given your findings, what do you suggest to therapists about how to treat depression?
Oh, the big question. I think there are different ways to treat depression, obviously, and I think that a lot of it depends on the therapist. And I think many of us know that in our own experience, when we're going to refer patients to a particular therapist, we refer them not only because of the particular therapeutic approach, but because we think they're very good at carrying it out. We also, we have some evidence of that with other patients. We also think that they have some expertise with this particular kind of patient that you're referring to them. So I think that it's very, very hard to make a general recommendation. I think there are several therapies. These aren't the only ones. There are behavioral approaches. I think in some of the later cognitive therapies where people have been doing it, some people have been originally trained in that approach. I think it can be very effective. I think interpersonal therapy can be very effective. I think some of the straight behavioral approaches can be, and people are now doing more integrated approaches here. And I mentioned the client-centered therapy, and that's my old background. The client-centered therapy combined with process experiential components. So I think there are a number of different therapies that have proved effective. I think when we get down to our own individual practices, I think, as I said, for instance, in referring patients, we think about the therapist, the particular kind of patient, and so on, getting back to the whole complexity of this area in which we're working.
Okay, so I have one final question. It's actually more of a comment from me. You remind me of something we talked about earlier with this last comment, and that is it seems important that we start also doing research into how well does a therapy fits with a certain therapist, whereas a lot of the research that we're doing and also in training we're assuming just, you know, because we train somebody in a certain therapy direction means that he or she is going to be a good therapist in that area, but it seems to be that we do not really look into how well do certain types of therapy fit certain types of therapists.
Yeah, I couldn't agree with you more. I think and I'm so glad you brought it up, Kim. I think it is such an important thing to think about, and such an important thing to think about in training therapists. And often therapists get trained in a particular approach, not necessarily because they chose it, but this is the place in which they're getting their training, and this is the primary training. I think now, as the years have gone on, that a lot of programs do give people more opportunity to get experience with various approaches. I think there's so many differences. When I think of, I had hoped to keep the videotapes and couldn't because of our agreements with the research sites. I wanted to study the therapists who not only had the best results, but who we felt was such an outstanding therapist with CBT, and the same for an IPT therapist, and sort of get some idea of more also. And I think we need to look into that. What kinds of personality characteristics, what kinds of preferences therapists have, and how that matches particular therapies. And I think in both of the cases that I'm talking about, there was such an incredible fit between the therapist and their way of going about things in life generally and the therapy that they were carrying out. And so I would love to see people doing more work in that area. I'm really glad you raised that. Good way to end the session.
Well, thank you. I'm just going to thank you a lot for sharing your knowledge with us and sharing your stories and your thoughts. And so I'm very grateful that you were here, and I'm going to end with an announcement that from next month on we will start with a new series of webinars that are called Dissertation Dissemination Webinars. We've sent the announcement of that this morning, so it should be in your inbox through the SPR listserv. And so I want to ask people to read the announcement. If you are a student in your final year, you can apply for talking in this series of dissemination, dissertation dissemination webinars. And so then the one in December will actually be done by myself. It'll be the first one, so we decided not to put you out there and one of us be the first one to do it. And we will start with the first 15 minutes with an explanation of how it works, how you can apply, etc. So even if you're not interested in the topic, please attend for the first 15 minutes. And after that, you can decide for yourself if you want to stay. So thank you again, Irene. And I'm going to close down the webinar for a bit.
Okay, I had the pleasure.